Type I hypersensitivity is a typical hypersensitivity or allergic reaction that can occur with food allergies, allergic rhinitis, bee stings, pollens, dog dander, and it's all beautifully painted by Monet. Type I hypersensitivity is an allergic response that depends on IgE. And Caravaggio presents a beautiful fruit basket that carries a lot of potential allergens. So with this allergen is presented to the B cell will process it and in turn present the specific T cell epitope that differentiates the T cell into a Th2 with mainly production of interleukin-4 that will produce the differentiation of the B cells into memory B cell and plasma cell. Most importantly, with eventually the production of IgE. IgE is critical for all allergic responses, and it's the one that characterizes the type I hypersensitivity. Why IgE? IgE is recognized by the mast cells that carry the IgE receptor. And when this IgE is bound to the allergen or the drug that's immunogenic, the mast cell will have an effect on smooth muscles, blood vessels, mucous glands, platelets, sensory nerve endings, and eosinophils. This produces a typical allergic reaction with sneezing, itching, pain, edema, swelling, and it can be really fast. The reaction could be 5 to 30 minutes. The manifestations could be anywhere from mild to severe manifestations, and they are basically wherever the allergen or the drug that's immunogenic has been encountered by the body, either respiratory or GI or the skin. There's a lot of edema and swelling. Now, while the majority of the allergic reactions could be mild, they can also be life-threatening. Type I hypersensitivity anaphylaxis is lethal, and it should be treated appropriately. This is a painting of Ophelia, who was gathering wildflowers, and who knows, she may have actually died of type I hypersensitivity anaphylactic reaction. The Sampson criteria are an approach to evaluating anaphylactic events, and this is encouraged to be used specifically when we're looking at therapeutic drugs as antigens for potential immunogenic response to drugs. But it can be used in the clinic, and it's actually extremely useful in the setting, for instance, of an emergency room. The Sampson criteria were published first in 2005. There is a follow-up paper, 2006. The criteria remain basically the same. And these are extremely useful. From the paper, it quotes, anaphylaxis is highly likely when any one of the following 3 criteria are fulfilled. And the key importance of this is, remember that anaphylactic reactions are life-threatening. So let's take a look at them in a bit more detail. The first criterion tells us that the patient presents with an acute onset of an illness that involves the skin, mucosal tissue, or both. There's examples of the kind of manifestations this means. So in here, we are in the presence, let's say in an emergency room, or a patient's given a history of an acute involvement of the skin. They do not know, do not remember, or cannot tell us if they have been exposed to an allergen. So that's why it's very important. Criterion number 1 is actually agnostic to the potential allergen or the drug that could be immunogenic. It's extremely useful when we do not have the complete history, but we have a presentation in the emergency room. Besides having the skin or mucosal tissue manifestations, there has to be at least one of the following, which includes respiratory compromise, or reduced blood pressure, or any symptom or signs of end organ dysfunction. So this is very important. The patient is coming with shock. The patient is coming with incontinence, wheezing, bronchospasm, and they also have some sort of skin or mucosal tissue. This is an emergency. It has to be considered an anaphylactic reaction, even when the potential allergen is unknown, and the patient has to be treated accordingly. Let's look at criterion number 2. In criterion number 2, 2 or more of the following should occur rapidly after the exposure to a likely allergen for that patient. Why am I saying this? Well, the patient is giving a history of having had a reaction to a particular drug, and they may not have known that they were getting the same drug with a different name. Or they know that they are allergic to bee stings and they got stung by a bee. So when there's a likely allergen for that patient and the patient can provide the medical history, any two of these two is going to be making the diagnosis of anaphylaxis for quick treatment response. The first one is the skin mucosal tissue. Second one is respiratory compromise. The third one is the reduced blood pressure. All three were components of criterion number 1. And now we also have a persistence of gastrointestinal symptoms, which are particularly seen with food allergies. And so patient knows that they cannot eat some sort of a shellfish or seafood and they are exposed to it. They will be having these symptoms, and any two of these 4 criterion plus the medical history makes this highly likely to be anaphylaxis and should be treated as an emergency. Criterion number 3 is now just reduced blood pressure. That's all we know when a patient comes having been exposed to a known allergen for that patient. And when I say allergen, it also applies to immunogenic drugs. So if a patient actually is known to be allergic or to have an immunogenicity response to a particular drug, and they present as infants or children with low systolic blood pressure, or as adults with a change in blood pressure that's as defined, 30% decrease from the patient's baseline or less than 90 millimeters of mercury in the systolic blood pressure, this is indicative of anaphylaxis, again, importantly, with the history of the patient. So with the Sampson criteria, criterion number 1, when we cannot obtain a reliable history, but we have any one of these symptoms that the criteria is listed, and patient should be treated. Number 2, when we can obtain medical history and it's a likely allergen for that patient. And number 3, when it's a known allergen for that patient. Please do not wait to get any laboratory results to treat these symptoms. They are very quickly developed. It's a very fast response, and they could be lethal. So you might have confirmation of IgE levels after you treated the patient, but do not wait for IgE levels to make sure that you make the diagnosis of an anaphylactic reaction. The recommended references are attached, and I hope you enjoy and subscribe to my channel. Thank you.